Hello and welcome to everyone here in the Global Summit, the Olympics of Dentistry. I'm Dr. Amr Ikram from Egypt, and today I have a very special guest, my friend, my colleague, Dr. Mohammad Marwan. Welcome, Dr. Mohammad.
Hello, Dr. Amr. How are you?
How are you? Okay.
I'm good. Thank you very much.
Good morning, good afternoon, and good evening to everyone all around the world. Today we have a very interesting lecture. It's about conservative implant placement. And like Dr. Mohammed likes to call it, placing implant the kind way. So it makes you feel that it's really kind to place implants. It's really a good approach to our patients, putting implants or placing implants the kind way. Let me introduce Dr. Mohammed. Okay. Dr. Mohammad Marwan graduated in 2006 from Cairo University. He then had his master's in prosthodontics, followed by his PhD degree from the same university. He had an experience for more than 12 years in 5 different universities here in Egypt, and he is currently an assistant professor in Fayoum University. Dr. Mohammed also had a fellowship from the Egyptian Society of Oral Implantology, a national board from the USA, and an advanced implant diploma from Napoli in Italy. He's the course director of the Comprehensive Implant Program since 2016. He's an instructor in the Egyptian diploma in the Ministry of Health here in Egypt. And of course, he's an international speaker and a key opinion leader, especially here in Egypt and the Middle East. Welcome, Dr. Mohammed.
Thank you very much, Dr. Amr Ikram, for this amazing opportunity and for this introduction. I really appreciate that opportunity. It's really my pleasure to be with you, everyone, and it's my pleasure to be with my professor and my mentor, Dr. Amr Ikram. I'd like to thank you again for that opportunity. And as you were just talking about the practicing implants the kind way, we're going to present actually different approaches in implant dentistry, not only the surgical part, but other things, how to be very conservative in the whole implant dentistry, experiences. So shall we start?
Yes, please.
Okay, so let's start. Okay, so I hope it's clear, the presentation. Let's make it a bit bigger. All right, here you go. So is it clear now, Dr. Amr?
Yes, okay. You can go on right now. Okay.
Yeah, we'll start. Perfect. So we're going to talk about the Conservo-Implantology, practicing dental implants the kind way. First of all, before going through the idea or the lecture, I have to show the theme of the lecture. Actually, the first slide, when you see the first slide, it aims at the outline. The second slide, the idea of the lecture, and when I'm presenting one of our clinical cases, so it's going to be the third slide. So as a prosthodontist, actually, I'm passionate about implants, but in a different approach. I always, as a prosthodontist, I'm always conservative in most of my surgical and clinical approaches. And this is what I'm trying to present in my lecture today. So let's, and please feel free to ask if there's a chance to interact together. Please do not hesitate to leave your question and we'll get back to you. So talking about the outline, we're going to first of all deal with the investigations and medications, the role of radiographic surgical stents, the drilling protocol, removable options in implant dentistry, immediate implant placement, modified ridge splitting, closed sinus lift, and implant angulation. Actually, I'm not going to deal in depth in each item of those. I'm just going to talk about an approach, how to be conservative, how to reach the max results, the maximum, the best benefits by following these guidelines in your daily clinical practice, in your daily clinical implant practice with the least invasiveness and the more conservative approach. So let's start. The idea is the 2P rule. In our clinics, we are all keen to do this 2P rule, something that I call the 2P. It's played safe and the patient is expecting a painless treatment. So what about these two? First of all, to play it safe, you have to be well prepared medically. So you have to ask about some laboratory investigations, including the CBC, complete blood picture, international normalized ratio, serum calcium, serum cholesterol, vitamin D, and glycosylated hemoglobin. Not only this, but also history. There should be a proper history. If the patient is complaining from any medical problems, allergy, whatever, it should be there. So talking about the CBC, it just gives us a reference about the general health. INR, definitely, we are always conservative in avoiding the bleeding. Actually, it's not only conservative, it's actually a must. The serum calcium and the vitamin D, it shows the bone quality and how is it essential in our implant placement and in the success of the implant. And a lot of many studies have shown that the cholesterol, serum cholesterol, have something to do with the success of the implants. And finally, the glycosylated hemoglobin, which is a more accurate test in comparison to the blood sugar, either random or fasting ones, because it gives you the reference of the last 3 months of the sugar in the blood in the RBCs. So that's why it's more accurate. And when we're talking about the glycosylated hemoglobin, we're talking about it should not exceed 7. In some research papers, it might reach to 8, 9. Actually, Carl Misch has stated that you could work up till 10, but provided that there is no any other risk factors. So these are the things to play it safe. So let's go to the other P, if you can remember. Let's go back. We're talking about the 2P rule, play it safe and painless treatment. So play it safe, you're avoiding the failures and you're avoiding any complications that might occur in your clinic. But talking about also the painless and also play it safe, we're talking about the antibiotics administration. And it comes here to Esposito in his systematic review in 2013, where it was found out that administering antibiotic before implant placement, definitely together with the chlorhexidine mouthwash, enraise or higher the success rate of the implants. So let's go to another systematic, a recent one, which was 2018. It stated that antibiotic prophylaxis is protective against early implant failures. So it's better to prescribe antibiotics to your patient before the implant placement, because this, together with the chlorhexidine mouthwash, because this actually increases the success rate of the implant placement. Not only this, another research paper, they recommended the actually, it was a double-blind parallel group placebo study, where placebo-controlled study, where it stated that the non-steroidal ibuprofen pre and post-surgery is very effective, together with the dexamethasone. And by the way, you can prescribe your patient an ibuprofen before the surgery, together with the dexamethasone. Actually, this decreases the pain during the surgery, especially when you're talking about the patient with the pain threshold, with the problems with his pain threshold. So ibuprofen is considered a very golden option. Also, other research paper talked about the local dexamethasone infiltration after dental implant placement, and this is actually one of my daily prescriptions after implant placement because of the bone removal and what so on. So it's better to administer dexamethasone and diclofenac potassium together, where this decreases the pain and post-operative edema. So this is one of the recommendations, and to reach a very conservative approach. And actually, you all know that the dexamethasone it's one of the commercial names, the cataflam. So this is about the investigations and the medications. Let's go and move on to another important and essential topic, which is the role of the radiographic and surgical stents. Okay, so talking about the radiographic and surgical stent for full arch, and this is one of our main concerns in implant dentistry. What to do in the full arch cases? Most of the clinicians, especially the fresh grads and those who are passionate about the implant and surgery, they are interested in placing, in working and going for the full arch cases. So to make it clear, one of our let us first show these cases. So how do you find this implant? It's actually labially placed more than needed. It's not a prosthetically driven one. And the same here, and it led to the fractures of the implant or abutment or whatever. Sometimes clinically you can see that the abutment or the implant is centralized mesiodistally, but without an X-ray or without using actually the radiographic stent or the surgical stent, you would never be able to, in most of the cases actually, to be certain that your implant is mesiodistally well-oriented, coronally and apically. And finally, this is one of the complications. Actually, these are not my cases, but it's just to clarify the importance of the radiographic and the surgical stent. So these all approaches are considered wrong. And to avoid such errors and to overcome them, we will need to know, first of all, something about the mesiodistal space. So according to Carl Misch, the mesiodistal space between the two implants should be 3 millimeter. We all know that. And between the implant and the adjacent tooth is 1.5 millimeters. So talking about the mesiodistal space, what if the mesiodistal space is 8 to 12 millimeters? So what is our treatment options? Actually, we can go for an implant of 4.5 or 5 millimeters, and then we can leave like 2 to 3 millimeters mesial and the same as this in the distal. So this is a straightforward case or a scenario. Let's go to another scenario when your mesiodistal space is 14 millimeters. So actually, if we insisted on placing one implant of 5 millimeter in diameter, we would reach to the cantilever. This will act as a horizontal cantilever. And actually, here we can have another substitute, which is placement of the two mini implants. And by the way, guys, mini implants is considered one of the good options in escaping from these scenarios where the mesiodistal space is large enough. I mean, when we count on placement of the implants of 4 millimeters, you would leave here like 5 and here 5. So this will act as a cantilever on both sides. So this might lead to the prosthetic errors, and it might end up with the failure of an implant even after its osseointegration. Another scenario is when the distance mesiodistally is 12 to 14 millimeters. So it's like it's not above 14 and it's not below 12. So we have two options to escape from that, to solve that scenario actually. The first one is we can go for disking mesiodistally for the teeth, like we can go for some enameloplasty to reach to the 14 millimeters. Another option, which is one which is really favorable whenever the crest of the ridge enables us to do so, is the placement of the implant in a staggered orientation. As we can see, some clinicians call it the tripodal implant placement. Actually, we have made good use of the force distribution by placement of these implants in that staggered distributions. And in addition to this, also, we made use of our large mesiodistal space. So let's go to clinical life and how to be a conservative and apply our mesiodistal guidelines. First of all, you need a radiographic stent. A radiographic stent either by using the radiopaque markers, ball, guttaperca, whatever. And this is how it looked like after cone beam, after the CBCT, where this is the stent with the channel in the middle, and we'll show a case like that one. This is a radiographic stent with its channel. Okay, so to know where is the entry. And also you can go for the vacuum stent with the point entry. Actually, as you can see in that case, they are a bit palatal. You can just determine, especially in the limited mesodistal space, to be very conservative. You don't have to go for more than one osteotomy. Actually, if you've gone through one of osteotomies here, you would never have the chance to go for another one because you have a limited mesodistal space. So as we all know, failing to plan is a planning to fail. So let's go to one of our clinical cases. So this is the radiographic stent. Actually, it's made of barium sulfate, ratio 4:1 with the acrylic resin, and with midpoint or mid channels, as we can see. And then this is how we place our implants. As we can see, this is by freehand. This was our planning on one of the softwares, which is the Blue Sky. Actually, this is one of the softwares that I really favor, one of the favorable ones to me. And this is our planning, and this is the implants after their placement. So as we can see, by using the prosthetic guides, which is that one, we can be able to plan properly before the implant placement and avoid several osteotomies. It's just for the sake of the point entry, and they call it the non-limiting surgical guides. So one more tip, always try in the radiographic stent before the CBCT. This is really important. And definitely Dr. Amr Ikram is aware with one of these things, because sometimes when the radiographic stent is not properly seated, so you would actually plan on a wrongly seated stent before the CBCT, and this could lead to wrong planning, wrong implant placement, and so on. Another option is using the implant positioning kits, and this is one of the, actually this is not my case, but we use these things if you can't go for a prosthetic guides or a prosthetic prosthetically driven implant placement. You can use such positioning kit with different sizes. So to guarantee and verify the proper placement of the implants with actually we can get rid here from we can get rid of the prosthetic guide, and we can use such implant positioning kits instead. One more thing about the conservative approach in the full arch cases. Actually, as we were just talking about the implant placement in the full arch, we need the full denture, a complete denture. Actually, let me show you something. Here's our denture. So we did a duplicate for that denture, and then we can use also that denture as an index, as a putty index. Such a putty index could know the exact position during the setting of the teeth when we're going for a screw retained or a hybrid prosthesis or whatever. So this could be a good determinant for the labiolingual position of the teeth, and how is the distance labiolingually is enough or not, and also the occlusogingival. And this is how it goes like. This is our index, and this is the during the customizations of the UCLA abutments, and by using of such index by the gingival margin as an indicator, we can know the height of such abutments during its customization. But we have one important obligation for this side note to be achievable, is we should have done a proper vertical dimension and a proper centricalation in our denture. And it's a very essential clinical tip to avoid the wrong measurements in our centricalation and vertical dimension, which could lead to wrong outcomes. So now we're talking about the planning and in the full arch cases. All right. So let's go for another case showing the non-limiting surgical guide. This is the mesodistal space. It was exactly missing two premolars, 4 and 5. And this is our radiographic surgical stent, after the planning for the point entry. And as you can see, this is the clinical case. So, and this is our 2 implants after the placement. As we can see, mesiodistally, it's exactly like 12 millimeters, maybe 12 to 14. So it would never give you the chance to make a single mistake. And that's why using the non-limiting surgical guides or the radiographic guides, or even both of them, could spare a myriad of complications that might occur afterwards. So it's just a very simple thing. Just take an impression and go on for a setup or a wax up, and then go on for the vacuum stent just for the sake of your point entry. All right. Another clinical case to verify and to show the implant placement using the radiographic stent, or sometimes even the surgical guide, or sometimes both. Here's the missing 4 and missing 6. In that case, this patient was seeking a bridge, and as you can see, we had the bone parameters was fine in terms of height and width. And this is our surgical guide and non-limiting surgical guide for the implant placement, just for the sake of the point entry. This is after opening the flap or releasing the flap, and then during the drilling. And this is our picture afterwards. As you can see, it is a very reliable option in implant placement. Very simple, very cheap, with no any complications with the actually we can get rid of the multiple osteotomies to be done in that case. So as we can see, this was the second module. Let's go for another topic in that module by using the fully surgical guides. So we were just talking about the radiographic stent, the non-limiting surgical guides, and the fully surgical guides to reach to a prosthetically driven implant placement. Actually, the fully surgical guide, we're going to deal with this side only, and we did it. Actually, the bone was the bone diameter was 6.8, and in the other side, which is the molar side, was 8.2. By the aid of such surgical guide, and this is the 3D printing for the cast or for the model after its scanning. And here is the case after the implant placement. As you can see, it's really it eases your surgery, and since we have a good platform in the bone, so we can even sometimes go for a flapless approach, just go for a punch followed by our 2 implant placement. It's one of the reliable methods. So what I'm trying to say is we can make good use of stent, radiographic stent, the surgical non-limiting or a fully guided ones, or even all together, for the reach of a conservative approach in our implant placement. Okay, and sparing bone, and also sparing much time, and this could lead to a maximum outcomes and more patient confidence. This is the case actually after in the second stage, and here how it looks like after doing our bridge. So we're done with the investigations and medications and the role of the radiographic and surgical stents with all its types. Let's go to another interesting topic, which is the drilling protocol. So when we're talking about the drilling protocol, we're talking about the speed, the torque, and irrigation. Okay. So actually going through the research papers, and lots of them, it was found out that to lower the speed during the drilling protocol is really highly favorable to avoid the bone necrosis. And also it's called the biologic drilling, because you can make use of this autogenous bone. And so just keep a mortar and a pistol beside you, and you can place your autogenous bone there during the biologic drilling, which is the bone collected during the low speed drilling. Actually, sometimes it could reach to 50 RPM, depending on the bone nature. So it's recommended to go for a low speed. We're talking about below 400 RPM, depending on the bone nature, and raising the torque. Sometimes we can reach to 35 or 40 Newton per centimeter square. So that for the sake of biologic drilling, preserving the bone, reducing the necrosis, and reducing the heat generation. And actually, sometimes the marginal bone loss could occur due to the high-speed drilling. Some people may reach to 1,200 or maybe 1,300 during their drilling protocol. Actually, I'd recommend to be very conservative and to um, play kindly with the bone and be very gentle with your bone is and reduce the marginal bone loss is to follow such protocol. So this is will be by keeping the bone temperature below the osteonecrosis temperature, below 400 RPM, as we were just talking about, with the use of the irrigation, copious, cool, saline irrigation, sterile one, of course. One more privilege, or maybe we can call it one more advantage for the drilling protocol at low speed is it increases the tactile sensation, especially on dealing with the inferior alveolar canal or the sinus. Actually, we all know that the inferior alveolar canal is covered by a cortex, a bony cortex. So such bony cortex, on working with the low speed, if you found a high resistance, I mean, so it means that you're close enough, and definitely you're aware that you're close enough to the canal from the cone beam. But also working under low speed could encourage you to be, if you found something solid or like we're talking about resistance, this could be a sign that you should stop here. And actually, this is one of the cases that I was really close enough to the inferior alveolar canal. So I decided, definitely I always work with the low speed, but I decided not to place implants in that site because it was close enough to the looping or the looping for the mental foramen. But actually the disadvantage for that protocol is the time factor. We are all aware that it needs time, much more time than drilling under high speed. So actually, you should be aware with the pros and cons, and accordingly, you can deal with your cases. So I've decided to go on for a search and check what's the preferable speed to be used depending on the bone nature. But actually, this was reach an evidence-based opinion. This was very difficult because of the different designs on comparisons. Also, the study models, we cannot measure actually the heat generated couldn't be measured easily, and also the variety of the surgical tool used. So there was no clear evidence about the heat generation and the preferable, or let's say the recommended speed to be used during the implant placement or during the drilling for implant placement. But most of the research papers were aiming at a low speed below the 400 RPM. So this is the drilling protocol. So let's tackle another interesting option, which is the removable options. Actually, when patients are asked taking the decisions between the removable versus fixed, we all know that when they are given the option, actually they would always go for and they will always opt for the fixed ones. But actually meeting the desires of the patient should not be the only factor influencing the treatment plan. There are several factors, including the patient's age, the general health, the available bone, the cost, hygiene, oral hygiene, and so on. So my piece of advice and my recommendation to most of the clinicians all over the world hearing us here today is to think and always suggest the removable option. And by the way, it's one of the viable options. So let's talk about the guidelines for the removable implant over denture. Is it a big deal? This is our question. This is the idea. Actually, it's not a big deal. You just should be oriented with the guidelines to be followed in the implant supported overdenture. We have 4 guidelines to be followed during the implant placement. First of all, implants should be parallel to each other, and they should be perpendicular to the floor. I mean, like parallel this way and perpendicular to the floor at the same time. They could be parallel this way, but actually they're not perpendicular to the floor. So we're talking about parallel, perpendicular to the floor, equidistant from the midline, and at the same level. And this is one of the guides that I've seen in the research paper. It's written down there, the reference, where it could help you to reach that target. It's to make your implants parallel to each other, perpendicular to the floor, equidistant, and at the same level. And we all know that the crown height space should be 8 to 9 millimeters for the ball attachment, and if you're going for a bar one, for a bar attachment, 14 to 16 millimeters. We're talking about the crown height space. And to assist the restorative volume, talking about the crown height space, we have to follow such guidelines. The parallelism should be 10 degrees or within 10 degrees maximum, not more than that. We're talking about the parallelism. They should be parallel to each other, or if there is some inclination, it should never exceed, the difference between the two implants should never exceed 10 degrees. The reason for non-parallel implant placement in most of the cases actually is a flared maxillary bone. Sometimes in the maxillary cases, we have the bony protuberance or the bony undercuts labially, which actually sometimes is challenging in the implant placement. And consequently, if the two implants are not parallel to each other, this could cause the loss of retention, and this will need the maintenance every now and then. We'll need the maintenance for the nylon caps and the ball attachments and whatsoever. Finally, to solve such problem, so we can go to another option. We're talking about the parallelism in implant placement. If these two implants are not parallel and there is some discrepancies in their parallelism, we can solve that problem either by the usage of the bar prosthesis or sometimes the locator attachment, which enables you to use the angulations or change the angulations till 35 degrees. So let's check a clinical case. This was one of the cases after the implant placement, 2 interforaminal. And by the way, according to McGill consensus, which was done, I believe, 2008 or 9, there was a consensus that 2 interforaminal implants is considered the first treatment options in mandibular cases. So in mandibular cases, it's contraindicated to go for a complete denture. It's not an option anymore, doctors. Actually, our first treatment option in mandibular cases, in completely edentulous mandibular cases, is 2 implant supported overdenture. So, and this was our attachment, which is actually an equator, which is similar to the locator ones. If there is any, actually it's a low profile attachment, but with a very good prognosis, especially if there is some discrepancies in angulations, although this case had no discrepancies. And as we can see, this is the pickup, and the channels should be through and through. Our channels should always be through and through to avoid the acrylic resin being stuck there, and this could cause the movement of the female parts during the pickup procedure. So another case regarding the maxilla, maxillary implant placement, it's always recommended to place 4 implants in the maxilla, but actually there was a systematic review 2014 that found that 2 implants in the maxillary ridge could be considered as a very successful treatment option with a survival rates of 88 till and 98 per year respectively, when implants are less than 4 millimeter placed and non-splinted, like the usage of the bowl, locator, or telescopic crowns. So this is another case that I've decided with my team to go for only 2 implant placement, although we have planned to place 4 implants, but actually it ended up with only 2 implants. And also I did a big flap in that case for an alveoplasty. As we can see, the bone was very irregular with the many sharp bony edges. So I just raised the flap, and we went through the alveoplasty in that case after also the implant placement. And we had a problem here, and which is the implant was a bit labially inclined in comparison to the other one, and actually it needed maintenance. But during the follow-up and after the osseointegration, we've decided to place to go for a pickup with the thermoplastic materials instead of the rigid acrylic resin. And this is also a very kind approach in the pickup. And by the use of a certain materials called the iFlex, we did a pickup which was really fine by the usage of a certain adhesive which was provided with in that company, where we could easily go for our pickup on that flexible material and that thermoplastic material. And this was actually very kind to the patient, and the patient accepted it because, as I was just talking about, the bony protuberance and the bony undercuts over there. And this was the case after the pickup, and the patient was really pleased with the follow-up of 4 years, 3 to 4 years actually, and the patient was highly satisfied with that, with the outcome. So another clinical case showing and revealing the importance of the removable options. Actually, this was the case in the cone beam, and we did our plan is by starting off doing the plateau, removing some of the bone, and then going for expansion. This was the case before, and then we went through the expanders by the usage of expanders. Take your time, be gentle. It's a very non-invasive approach, very kind one to the bone by the usage of such expanders. And you know what? If you don't have such expanders, or you're not prepared with them, there's another substitute. As we were just talking about the drilling protocol, you can go for a speed of 170 RPM and a torque of 35 Newton per centimeter square, but using a reverse one. And it will act as an expander. It will act as an expansion. And this is a substitute if you're not ready with your expanders. So as we can see here, after our implant placement, and here's the after implant placement, as you can see, sometimes I don't go through 2 vertical releasing incisions whenever possible, with minimal lacerations, also as a conservative approach. So what was done in that case, to sum it up, this was the case before, and this is the case after. First of all, we went for a plateau, 2 to 3 millimeters, and then expansion, taking our time, doing it gently, and then 2 implants were placed interforaminal, equidistant, parallel to each other, perpendicular to the floor, and at the same level. So this was the case, and the bone width before, and this is the bone width after. And going back through the guidelines for the pickup, as we were just talking about, you have to place a rubber dam or gloves or nylon cap, I mean any separating medium, to avoid the escape of your pickup materials below the attachments. And then you can go for injecting your self-cure acrylic resin or your pickup materials with the channeled through and through, as we showed the previous slides. And then you can go for the pickup, and this is the case post-operatively. This was before, and this is after, by the aid of the ball abutments. What I'm trying to say in that case is sometimes removable option is considered a viable one. It's considered really a good one. So why not to market for that one? Actually, you could spare the patient much time, much effort, the lower edema, less bone loss, and even lower cost. And actually, patients appreciate that. And one final case showing also the removable options and the feasibility of the implant placement, interforaminal. This is our flap incision, and this is the reflection of the flap, and these are the two implants. Don't forget, these are the two implants after the implant placement. Don't forget the surgical procedures and the precautions by the aid of the prosthetic guides through and through channels during the pickup, parallel to each other, and equidistant from the midline, perpendicular and at the same plane, perpendicular to the floor and at the same occlusal plane. So this was the removable options. So let's jump to another interesting topic to most of our followers and most of our doctors is the immediate implant placement. What are the challenges and what are the goals we are trying to reach here? Actually, during the immediate implant placement, we should never overpromise our patient. So we always say, we always have a quote that I really respect: underpromise the patient and overdeliver. So we never promise the patient, especially in immediate implant placement cases, that we're going to place the implant at the same time of the extraction. Why? Because we have some challenges. These challenges include thin buccal or labial plate of bone. Sometimes there is lack of sufficient interseptal bone, and other cases there are three-rooted premolar cases. So actually there will be minimal interseptal bone in between the three roots for the implant placement. So for a prosthetically driven outcome, it would be really challenging. So our goal in immediate implant placement is to avoid the slippage during the creation of your new osteotomy. And this could be done by the aid of the ultrasonic tips. Very simple one, a very kind one to avoid the slippage of your drill. Debridement could be really essential, especially if there is any pathosis or periapical problems, by the use of the bone curette. And positioning and stabilization of your implant, and also a slow resorbing bone graft material also prevent actually the ridge resorption. So let's talk about the prosthetically driven implant placement, facts versus reality. What am I trying to say here? This was a case with a patient with a flare-up in her endo, and actually the patient was rejecting the idea of going for a retreatment and insisting for an extraction in that hopeless premolar. After the extractions, it was found out that the interseptal bone was actually not sufficient to place the implants. So I'd recommend that, and I've seen that in several case reports, which is really one of my conservative approaches, is to place the implant in the palatal root. They call it the stress-bearing one. But actually, it's going to be on the expense of the interseptal bone to keep the prosthetically driven implant placement. So I'm talking here about an implant placed in the palatal root, but on the expense of the interseptal bone. And such interseptal bone acts as a buccal plate of bone. And in this case, although the jumping distance or the jumping gap was more than 2 millimeters, I'd rather, in that case, I didn't place bone graft, and actually the case was really good. And this is after the suturing, and this is after the osseointegrations, after 4 months from the implant placement. And in that case, let me go back. In that case, I'm going to depend on the primary stability in the apical 3 millimeter, the 3 millimeters apically, to have my primary stability. So you can go in some cases, especially when the interseptal bone is minimal, for the implant placement in the stress-bearing root, like the palatal one in the upper premolars, but on the expense of the interseptal bone. And this was the case, this is after the abutments, and this is the case after the crown. The patient was more than satisfied with the 5 years follow-up. Another case with the same concept, a patient referred with an implant showing the threads, the metallic threads, and complaining from discomfort and pain in that case. And this was the cone beam. Actually, it's a disaster, showing all the implant almost outside of the socket, and this is after the crown removal, and then we remove the abutment, and here we are removing our implant, the old one, and then we went through a flap with the two vertical releasing incisions, and this is when it mandates us to open two vertical releasing one to deal with the defect, and this is actually our defect. As you can see, the shadows or the threads of the old implant is apparent. So my approach was just to go also palatal as in the previous case and place here a bone graft in buccally, and this is the parallel pin. This is our x-ray with the parallel pin mesiodistally, our new implant placed there, bone graft, membrane, and this is the case after its osseointegration. Actually, very pleasing outcomes to me. In that case, the idea here is to place your implant palatally whenever possible, even sometimes. In that case, as we can see, I tended to use an angulated abutment, but actually, why not? I did that for the sake of placement of the implants palatally and verifying the success of the newly implant placed in that site. So let's go to another approach in the immediate implant placement. When we're talking about the multi-rooted teeth, we use the remaining roots as a guide. This is actually one of the simplest case and well documented with a myriad of case reports in the literature, showing that you can sometimes place your implant between the two remaining roots. This is the case. As you can see, we were planning to place an implant at the 6 and the 7, okay? And the implants would be here, tooth-guided, multi-root tooth-guided implant placement. And this is after the point entry drill and the placement of the parallel pins. As you can see, this is osteotomy. After the drilling was achieved, we removed the remaining roots and we placed our implant. These are the remaining roots after their extraction. And this is some autogenous bone during our biological drilling protocol. And we placed the biologic bone in the socket. And here, our two implants. And this implant was placed. I just inserted it lower after taking that x-ray, as it's an immediate one. So it should preferably be 2 to 3 millimeter subcrestally. And this is how it goes like with such cases. Another immediate case, another immediate implant case, showing a conservative trick in that one. And let us go through the case to show that simple trick. And it's an easy one for those who are not practicing the perio or surgery, for the prosthodontist like me, who needs actually to play it safe and quick, where the two remaining roots here were extracted after the crown and the post. They were hopeless remaining roots, and these are the remaining roots after their extraction, as we can see. And then we placed the two drills, pilot drills, and one preceding it to detect the parallelism. And here's the abutment guiding pin, or the parallel guiding pin. And as you can see, there is a shadow for the thin labial plate of bone. So in that case, I'd rather to go for a bone graft, particulate bone graft, and xenograft. And also before it, there is some autogenous bone followed by the xenograft, and then our membrane, and then placing the tacks. And this is one of the conservative approach. Instead of suturing it, we can spare the patient some time by placing the membrane tacks, and 2 of them buccally and also 2 of them palatally. One of the simple ways to place your membrane tacks is to place it, to fix your membrane properly for a superior outcomes, is to place your membrane tack palatally, buccally, and sometimes also we use our cover screw or even the healing collar to fix the membrane from occlusal approach. So actually, this is one of the easy ways to fix your membrane for superior outcomes. So I'm about to end my presentation, but I'm just going to go through also some conservative approach in the ridge splitting techniques. We were saying here that the Siemens spatula and the time factors are your friends. And this is actually one of the techniques that you can easily use in your daily practice with no need for the microsoles or whatever. And before going through that, can you just give me a second, please? Something wrong with my elimination? Yeah. So I'm back. So Siemens spatula and time factors are your friends. So this is a case with the 2.25 millimeter after the cone beam in the bone diameter. Actually, it's not an indication for even a ridge splitting. I know that, but we can also play it safely and go for a conservative approach in ridge splitting. And I did this case with my mentors, Dr. Khalid Zikri and Dr. Ahmed Fayyad, who actually gave me much experience in that field by the usage of the lancet in the ridge splitting, followed by the Siemens spatula. But actually, you have to take your time. You have to give, because we all know that the maxillary bone is spongy bone. So give it some time so that you can expand your ridge, labiolingual. And what happened was expected actually is the fracture in the labial plate of bone. Here it is. Actually, it's very clear, very obvious that it's fractured. So, and there was primary stability from the palatal and the apical 1/3, and then bone graft and membrane was placed. And by the aid of the OSTEL, the ICQ, the ISQ, and the reason frequency analysis, and also by cone beam, another cone beam after 5 months from the implant placement, it showed well readings for those 4 implants. And this is the implants. Actually, they are not parallel in all the ways because it was really a challenging case. And we took primary impressions for the splinting of for a special tray, an open tray, implant level impression technique for the accuracy of that. And then we went to splinting by using the Duralay, and this is what they call the verification jig. And this is after our impression was taken, and this is the patient doing the meta try-in. We did him a Siemens retained bridge on such 4 implants from the 5 to the other 5, where what favored and helped us in doing that treatment approach was the lower denture. Was a non-natural teeth. It was a lower denture, so this considered as a decrease in the risk factors. So what are the learning points in such modified ridge splitting technique? Actually, you can place your implant at the same surgical appointment in a bone of less than 3 millimeter in width. Condensation, you can go for the maxillary cases, more common than the mandibular cases, which could enables you to condense the soft bone and expand it easily. Almost no drilling. You can even use the osteotomes, expanders after the ridge splitting cases. And I'm going to show another case right now. And finally, intact periosteum over the labial cortical plate of bone, if it's possible to preserve your periosteum, because as most of the authors claim or say that periosteum is the best possible membrane containing, as it does a rich supply of osteogenic cells are there. So always preserve your intact or your periosteum and keep it intact. Another case with 2 different ideas. First of all, it's the usage of the Siemens spatula in the ridge splitting, and the other one is the usage of the mini implants. And this is what I was talking about. It's an upper lateral case. So we all know that the upper lateral cases, or the upper lateral is definitely out of occlusion. So you don't have to place a big diameter implant, or I mean a conventional one, like a 3.5 or maybe larger in that case, because in that case, the diameter was just crestally, maybe the first 4 to 5 millimeter was 3 millimeter, and then it tended to grow or to be larger, 4.5 millimeter, as we go apically, and the bone height was fine. So I selected the mini implant in that case also after the ridge splitting. This is the case after the crestal incision and after the reflection of the flap. Actually, as you can see, no vertical releasing ones. I was dealing with I did only a pouch here, but no any releasing ones to be conservative. And then I started the same favorable or my favorable technique, which is the usage of the cement or the lancet first of all, and then followed by the cement spatula. Just give it some time, be gentle. The peace of mind should be there. You have to be very patient in dealing with such cases, and it will go really with a high success rates. So this is the Siemens spatula, and then this is our osteotomy. Actually, there was a kind of a shadow where we placed only bone graft in that pouch with no any lacerations, with no membrane. I just placed my mini implant, and I'd always recommend mini implants in the lower anteriors and the upper lateral. I mean, where the cases where it's not stress-bearing cases, the cases where there is no high forces. In that cases, you can go for mini implants. Why not? It's still a good option. And this is the implant mesiodistally, and this is our bone veneering graft materials placed labially. And we then did a customizations for a crown with a high success rates. Another final case showing the modified ridge splitting technique after the flap. And then also they used the blade number 11 followed by the blade number 15. And then I took my time. I was really patient in doing that case. And by the way, we have a problem in that case, is that it has two problems. The first one is the vertical defect, and the second one is the labial defect. So we had two defects in that case and two challenges actually. So after the ridge splitting, I also used the mucoperiosteal elevator to expand my bone. The mucoperiosteal elevator with two sides. I used the small side, and to go on with, you can use an osteotomes, you can use an expanders, whatever you like. And this should be the level of the implant to be placed where there is a very obvious vertical defect here in that one. And this is our expanders. This is the osteotomy after the expanders were placed. And then, as you can see, the implant was placed at the same level of the cemento-enamel junctions of the adjacent teeth, and then a bone graft and a membrane was sutured there. And this is the case. What I'm trying to say here is without harvesting bone, you can use the bone graft and the membrane as guided bone regeneration, but placing some autogenous bone from the one you got from the biologic drilling and placed over there, followed by the xenograft and then the membrane. This could lead to good results. Finally, I'm going to talk about the closed sinus lift in a few seconds maybe. All what I'm trying to say is a very small trick that I really learned from a professional friend of mine. Using the denser bears, or what they call the versa bears, the versa drills, the first bear should be 1 millimeter below the sinus, then the second bear till the level of the sinus floor. Then we increase 1 millimeter with each bear at the speed of 1,200 till 1,500 with a pumping action. But my trick here is it's preferably to place a membrane during the sinus lifting, closed sinus lifting procedures. Preferably to place a membrane so that it could secure the Schneiderian membrane, and even if a small tear could occur, sometimes the Schneiderian membrane could help in its regeneration and the rehealing again. So And what we are aiming at is reaching to that white halo, and this is really a conservative approach to elevate your sinus, but it's only provided that the width should be 4 millimeter or more, not less than that, so that you can elevate your sinus 3 to 4 millimeters. Okay, our last module is the implant angulations. We should be oriented, we should be self-oriented with the alignments of the implants. Actually, in the posterior mandible, we are all aware that the submandibular fossa is here, which mandates the implant placement with increase its angulation as we go distal. So, in other words, we can say that the angulation could be 10 degrees to horizontal plane in the first molar, 15 degrees in the second molar, and 20 to 25 degrees if you go further. So, what I'm trying to say here is your implant preferably to be inclined lingually from the coronal aspect for 2 reasons. First of all, to avoid the lacerations of the arteries present in the submandibular fossa, and the second thing, for a proper occlusion, because we know that actually the upper teeth or the maxillary teeth, it overlaps the lower one. So the upper teeth should be preferably labially inclined, and the lower teeth preferably to be lingually inclined. So as a clinician and as an implantologist, we should be oriented with that angulations, and we should have that mental navigation in our implant placement. And let me say something before going through our case. Is in the anteriors, in the cement retained one, the prosthetic axis should be in the incisal edge, while the screw retained, our prosthetic axis should be from the central fossa. But in the posteriors, both are similar. So this is, I'm talking here about the point of entry of our implants. So our last case to be shown today is how to apply the angulations. So let me go back again. We were talking here about the posterior. So what about the anterior ones? In the anterior upper centrals, preferably to be inclined 12 degrees labially. And this could facilitate the occlusion between the upper and lower, and preserve the overjet and the overbite, which is the vertical and the horizontal overlap between the upper and lower anterior teeth. So you should be well oriented with such implant placement by placing your implant 12 degrees. I know it's a bit challenging. Sometimes the usage of the non-limiting guide could help you. Sometimes a fully guided fully surgically guided one could help you also, because actually it's not the easy thing to be achieved, is to place your implants only 12 degrees labially inclined. So let's check that case. As you can see, this is a young female patient. She was complaining from her look and her appearance, and she was seeking an implant placement. We took an alginate impression, a primary impression, for the sake of the prosthetically driven non-limiting guide, for the sake of the point of entry. And then we placed our implants with the 12 degrees labial inclinations. As we can see, here's the upper anterior implant placement. And then this is a jig for the ease of the abutments. And this is our bridge after its delivery. Another, as we can see, this is a small trick also. If you're having more than one abutments, to splint them together and to place them in the proper hex position. You can actually ask the lab, or you can even do this in your clinic by usage of the Duralay or resin or whatever, in splinting them together so that you can place them properly with the proper hex position inside the patient's mouth without any confusion. And this is the case after the delivery and after the cementations of her anterior bridge. As you can see, the proper implant placement with the proper angulations could lead us to a superior outcomes. So this was the case before, and this is the case after. This is a profile side view before, and this is the case after. So I'm almost done with my lecture. I'd just like to tell you my take-home message. Investigation and medications are very essential to play it safe. The first P, to do a painless procedures, is really mandatory and could lead to a more higher trust and uh, higher faith in your patients, in you, I mean. The flap approach and the suturing techniques, preferably not to go to a vertical releasing one in all of the cases, and suturing techniques, preferably also to go on for your stitches um, um, as soon as possible without the exposure of the flap for a long time. Removable option is a viable option to be clarified to the patient with all its pros and cons, but respect the guidelines. And we should never forget that, because we don't have to opt for the fixed options. Also, the removable option is considered a viable and reliable one. Thermoplastic materials represent the coming era, especially in the bony undercuts. You're so gentle in your pickup, as we have shown in our case. It's one of the favorable materials that the patient really accept. An immediate implant placement, no overpromises, and self-evaluation as regard to the centralization is really important. Sometimes when your palatal root is a bit far and it's not prosthetically driven, you have the right decision to say no. We can just go for a socket preservation and then we can place the implants, and this is by avoiding the overpromises to your patient. Membrane tacks are considered as a good substitute, time saving, instead of suturing your membrane. Mini implants could be really a good option in upper lateral cases and lower anterior cases, those that are out of occlusion. Modified ridge splitting cases, especially in the maxilla, by the usage of the Siemens spatula, by the usage of the lancet, actually is a very good option with no need in some cases, with no need for the use of the microsaws or the expanders or whatever, especially in the narrow ridge buccolingually. Closed sinus lift is not an out of reach option. You can still do it by the usage of the Densibers or the Versabers. And predictability of angulation is essential before implant placement. Before your implant placement, you have always to the angulations of the implants. If it's in the upper anterior area, you're going to place it labially inclined, like 12 degrees. If you're going to place it in your lower posterior area, it's going to be lingually inclined. So predictability is based on your knowledge. Okay. Thank you very much for that opportunity in the global summits. And please, you can feel free to contact me on my Facebook account or Facebook page, M Marwan Rahal, MARWANRAHHAL. This is the Facebook page. Instagram, dr.m_Marwan_Rahal, RAHHAL. Or you can even email me on marwan84us@hotmail.com. Feel free to ask or leave your question. Do not hesitate to contact me anytime. I was really pleasured by being with you today. I hope I tried I conveyed something to you, dear doctors over there. Thank you very much, and let's get back to Dr. Amr Ikram. Dr. Amr, are you there?
Thank you, Dr. Mohammed, for the nice presentation and many tips you told us about implantology. I like the lectures that have those tips.
Thank you.
Not any one of us can get all the tips. Everyone has his own tips. So if you can get extra more, that would be very
yeah, exactly. Yeah, it depends on the clinician.
I have a couple of questions.
Sure,
okay.
Sure.
You said you like to play it safe, and at the same time you like to be conservative. Okay. What if you have a borderline case? Would you rather play it safe, or would you prefer to be more conservative?
Would you mind just repeating the question again, Dr. Amr?
Okay, suppose you have a ridge which is not very wide. Okay.
Yeah. Okay. Yeah.
It's a borderline case.
Yeah.
You can't play it safe. Okay, but you can guarantee it. So would you guarantee your surgery with a flap, or will you go for a flapless, safe conservative surgery, but you're not feeling very safe while doing the surgery.
All right. So, well, let me first of all say it that way. I'd rather to let the patient aware with the case first of all. The patient should be oriented with the case's scenario, and there might be a risk. So, if the patient opt for a two-stage surgery, or if the patient is against the, you're talking about a flap, yeah? You're talking about the flap, Dr. Amr.
Yes, yes.
Yeah, so if the patient is with the idea that we could go for the risk one without opening a flap, okay, but in that case, I believe not only I'm going to be dictated by the patient's opinion, but I would play it safe and go for a flap as well, besides explaining that to the patient. So I believe I'm going to go for both. Explain to the patient that I'd rather to go for a conservative one, but actually in that case, because it's a borderline case, I'd rather to open a flap and even go for the 2 vertical releasing incisions so that I can be, I could have this proper accessibility and visibility as well.
Okay, so me too. I like to play it more safe than conservative. Okay, if I can do both, it's okay.
Yeah, exactly.
So, okay, does being a conservative dentist affect you economically and marketing-wise in your clinic or in your office?
Well, that's really a good.
With other dentists, surgeons like mine, who like to open flaps a lot.
Yeah, well, let me say something about that. Talking about the conservative approach, you would spare the usage of bone graft membrane in some of the cases if possible. So this would spare also the patient more time and more money. So you'd be less invasive, and actually it could be a point of strength in your marketing. And when you're talking about if the case permits to place your implants with no bone graft, with no membranes, that would really be a positive merits, I mean, to the patient with good outcomes. So I believe, yeah, the conservative approach for the patient, they appreciate that, but whenever the case permits.
Okay, one more question about drilling in bone. Okay.
Okay. Yeah.
You said you like to drill with low speed. Okay.
Yeah. Exactly.
I believe drilling in low speed in hard bone will let you want to make more pressure, and pressure increases heat more than low speed. Or were you referring to doing this in only soft bone?
Okay, so I always do that. To be very clear, I start my drilling protocol with the low speed, like we're talking about 250, 250 to 300, and then after my evaluation for the bone before the tactile sensation, I mean in the cone beam, it gives you like an indication. I know it's not a very true significance for the bone quality, but actually it gives you a signal about the bone quality. And then you go for the I go for the drilling protocol with the 250, and I just check how is it going like. If it's highly resistant, I increase the speed, and like 50 per 50 per 50 RPMs. Sometimes I could reach to 500, maybe 600 in the dense bones, in dense bone cases, I mean. But I'm talking mainly about the soft bone, like D3, D4, D5 bone. I'd rather to start with 400 or less RPM, but definitely not in all the cases. And I totally agree with your opinion. Is we don't have to go for the low speed or the low speed drilling protocol in all the cases. Actually, when the case or when the bone is highly dense, we don't have to go for the low speed. I mean, yeah, you could go for the a higher one, but I'd rather to increase it gradually. I hope you got my point, Dr. Ab.
Yes, sure. Yeah. Okay, my last question.
Sure.
It's an advice to the young dentists.
Sure.
And people who are abusing flapless surgery all the time. Can you give them a brief message?
Well, yeah, sure. Yeah, thank you for that question, and thank you for that incredible trick. Actually, most of the freshly grads in the lectures, in the workshops, in the courses, and whatever, they always ask this frequent question: is it possible to place my implant flapless? Because actually, their main challenge is the flap raising and the suturing techniques, plus the time consumption. So my piece of advice to all doctors there for that one, whenever the bone plateau is 7 millimeters or even above that, like 7, 8, 9 millimeters, I'd rather to go for a flapless one. But if you have the bone configuration crustally is an irregular one with an irregular anatomy, so in that case, I'd rather to open the flap and to remove that bone crustally, as we have shown in one of our cases. And one other thing, if the bone plateau is below 6 millimeters, in that case, there is a high risk in slippage or even the fenestration of the buccal plate of bone because actually they are blind, they are working blindly. So in that case, we would rather to go for a flap with a 2 vertical releasing incision if necessary. But in a nutshell, whenever the bone is 7 or 8 or above, we can go for a flapless one. And I'd rather also to go for a tissue punch as well, although some to remove the soft tissue and to avoid its impregnation inside the bone. And actually, some research papers say it's not. Some say, but actually, I'm with that using the tissue punch and then going for an osteotomy, flapless. But when the bone permits, like 7 or 8 millimeters and above.
Okay, thank you very much, Dr. Mohammad, and thank you for your time. I know it's your office time now. You are taking it's a valuable time, but thank you. I hope everyone enjoyed the lecture as I did, and thank you, everyone. And please don't go away. We have another webinar in a few minutes, so please don't go away. Thank you, Dr. Mohammad. Thank you, everyone.
Thank you very much. Thank you, everybody. You too. Take care, everybody. Take care.
Bye bye.
Bye bye.